to be here on this lovely spring day. Sarah will recognize one of my slides has a picture of Medicaid at the Crossroads, and I think that's a phrase we collectively, those of us who think about and work on the Medicaid program, have probably used many times during its 51-year history. But as it was true in other times, it is particularly true at this time. I think the evolution of the Medicaid program over the last 5 years, but really over the last 10 years or so, has been extraordinary and very different in kind than some of the changes that have occurred in its previous 40 years. So what I thought I'd do today is give you a sense of that history. Probably most of you, if you're sitting here on this lovely spring day listening to a talk on Medicaid, you probably have a fairly good sense of the program. And what I wanted to do is step back a little bit to talk about where it's been, where it is now, and what are some of those crossroads as we look ahead over the next period of time. It is, and this is a phrase I started using when I was at CMS, which got me into a little trouble with the seniors groups, because they would say, well, wait a minute, really, your grandmother can use the Medicaid program. It's very much a program for elderly people as well as people with disabilities, families, children, pregnant women. But it is a phrase to really try and capture how different the Medicaid program is today than what it was when it was first started. So it was started in 1965 along with that other program, Medicare, in the same federal legislation that established both programs. And it really was, you hear Medicaid talked about now as a welfare program in some places, in some states, some governors. I think it's not a welfare program, actually. I think it's a health insurer. It's a health care program. It's not quite the same as other health insurers programs, but it is not a welfare program. But its roots were very much in the welfare system. And so we understand that, and actually once you begin to unravel its history over the last couple of decades, and particularly just since the Affordable Care Act was passed, you see that those roots were very strong for a long period of time. So when I say it was a welfare program, it was because, for the most part, and there are a couple of exceptions, when it started in 1965 and for the first couple of decades of its existence, it was a fringe benefit. It was a tag-along to the benefit that people got when they applied for and were found eligible for welfare. Could have been welfare for families with children, which was the old AFDC program, Aid to Families with Dependent Children, or the precursor to SSI, which is Aid to the Age, Blind, and Disabled program. So if you were in those categories and you applied for welfare and you went through the process and you were able to get your way through that process and you were found eligible for welfare, at the end of that process they said, oh, and by the way, here's authorization to get medical services. They didn't give you a card. It wasn't a card. It was some authorization, usually a piece of paper that you take around to a willing provider that was signed up to the program. So it was very much an add-on. It was only available because the welfare programs were designed since the Elizabethan Poor Laws for the deserving poor. This health care program was only for the so-called deserving poor. Parents, children who were dependent children under the AFDC rules and their parents, and elderly, blind, and disabled people. But you were actually receiving cash assistance, not just look like those individuals, but you were very much receiving cash assistance and had gone through that process. And for those of you who have had an experience in the cash assistance world, you know that the goal of cash assistance in 1965, in 1765, and in 2005 is not necessarily to grow the program, not to get everybody who's eligible enrolled, but really to make it very transitional and to limit access to the program. And the idea is not to grow the welfare program. And so because Medicaid was attached to the welfare program, that similarly was the way in which Medicaid operated. It is very different today. In 2016, it covers over 65 million people, nearly 1 in 4 Americans. It is most people are covered through employer-based coverage, but if you think about it as a single insurer, a single program covering people, it is the largest one in the country. and it has very different eligibility and enrollment rules than it had in 1965, and in fact, very different rules than it had in 2005. And because of its size, because of its cost, and because of the import and the particular needs of the people that it serves, it is also can be a very significant driver of payment and delivery reform. So here's a picture of thinking about where Medicaid, at least for those under age 65, fits into the paradigm of healthcare coverage after the Affordable Care Act. So as you probably all know, under the Affordable Care Act, we retained the Medicaid program but grew it, we being the country, Congress, the president, retained the CHIP program, the Children's Health Insurance Program, at whatever level the states were at the time of the enactment of the Affordable Care Act. And then superimposed on all of that was the marketplace with the tax credits and the cost-sharing reductions, the subsidies available in the marketplace, or otherwise called, known as the exchange. And while there were separate programs, Medicaid, CHIP, and the exchange with its premium tax credits, the law took efforts to try and make a system, try and knit those programs together. And so I very much think about those programs together as a new coverage paradigm, with Medicaid really as the foundation of that new paradigm. If you think about it, for people who don't have affordable coverage at work, you now have a place to get coverage. And if your income is between 0 and 400% of poverty, you have a way to get a subsidy, a way to get some financial assistance to be able to get that coverage. It could be through Medicaid, could be through CHIP, and it could be through the exchange. Of course, in 2012, we had the Supreme Court intervening and saying, wait a minute, we're going to disrupt this picture a bit. And while they ruled that everything in the Affordable Care Act was constitutional relative to the challenges put before them in that case, the one thing that they struck down is they said the Secretary of Health and Human Services did not have the authority under the Constitution to penalize a state, take away their dollars, if they chose not to do the Medicaid expansion in the Affordable Care Act. So as a result, in effect, it became a voluntary expansion with states. And so this paradigm of coverage now has a gaping hole in some states, which we're going to talk about. But many of the features that I'm going to talk about in terms of the changes to the Medicaid program actually are in place regardless of whether a state has expanded coverage or not. So the gaping hole is very significant, but it doesn't change the other aspects of the Medicaid program that were significantly modified by the Affordable Care Act. So here's where we are right now in terms of that gaping hole, in terms of coverage. We have 31 states plus the district that have expanded, including Louisiana, whose expansion is been directed by the new governor in his first workday on the job with an executive order, with that expansion taking place implemented on July 1 of this year. So that leaves us with 19 states that have not yet expanded. And you see Louisiana really is the first Deep South state that has taken up the expansion. Arkansas was one of the earlier states that did it through the waiver, but we see a pattern here of states in the Deep South and in the Midwest that have not yet taken the expansion. And of course, there's Maine. You can, because it is an option now for states to go into the expansion, states can come in at any time. So hence, Louisiana is about to come in to do the expansion. The other side of that coin is a state can come out of the expansion anytime it wants as well. It is a voluntary program under the U.S. Constitution. And so what we had in Kentucky is a new governor coming in who had campaigned on, I don't like Medicaid expansion, I'm going to repeal it. One of the most successful Medicaid expansion programs in the country in terms of numbers of people enrolled and access to care. But that was not what the governor was interested in. That being said, once he got into office, he said, maybe I'm going to think a little bit differently about it. Lots of people would lose coverage, lots of healthcare providers would lose dollars, and the state budget, in fact, would have a budget hole because the Medicaid expansion has helped in that regard. So we need to look always at this map in a very dynamic way. States are coming in, I hope. We'll see a lot more of them come in after the elections this year. One way or the other, elections tend to be a time, state elections, federal elections, where everybody just stays still and says, it's not a time I want to jump in. So I hope we'll see some more states coming in next year. But we also have to be aware that when there's elections, legislatures, as well as gubernatorial elections, that things get rethought through. But let's also talk, so the expansion is usually what people are most focused on the ACA impact on Medicaid. But it's very much important to understand how different the way Medicaid operates, going back to that continuum of coverage. Going back to 1965, where the goal was to keep the welfare rolls low and therefore health care coverage low, we have a very different paradigm today, which is that we want people to be covered. It is the basis upon which we are not only making sure people have access to care, but it is the basis upon which states and health insurers and health systems and communities are really trying to build a stronger healthcare delivery system and a sustainable financing. So, very dramatic changes. If you look just 5 years ago, states were, as they say, a little bit all over the map on this, but there were amazingly, I think, no federal rules, really, on how a state ran its eligibility and enrollment process. Virtually no federal rules at all in the statute or in the regulations, because it was derivative from welfare. If you got welfare, you got Medicaid, right? And even though those links were broken in many ways across the decades, the federal law never evolved to say, well, wait a minute, we are our own program now. We're not just derivative from welfare. We should have our own rules. So what you had in some states is you had to bring a wheelbarrow full of documents in order to apply for Medicaid. You had to apply in person in many states. Many states changed that, but changed that only for kids, not for adults. Some states had drug tests. Some states tried to have fingerprinting. So the old rules continued to survive, and there was really no federal lever to say, no. The idea actually is if you're eligible, you get enrolled. So most of what went on for the decades leading up to the Affordable Care Act in terms of promoting enrollment among eligible people was talking about best practices. What could we do? Oh, look at state X, they did this nice thing. Why doesn't state Y do it? But if a state decided it did not want to do it, it was not compelled to do it. The Affordable Care Act changed that, and now in federal law and regulations, we have rules about no face-to-face interviews. What does that mean? It means it used to be, again, a carryover from the welfare days, that you actually had to go into a welfare office to apply for Medicaid. Well, if you think about the expansion of Medicaid over the years, not to mention the expansion in the ACA, you get a lot of working poor families, and they don't have the flexibility to come to a welfare office and spend 2-3 hours in a job that, working at a job that doesn't allow them that flexibility, or that either fires them or dings them in terms of income. No drug testing, no fingerprinting, streamlined applications. There's now federal rules on what the application needs to look like, and most importantly, what it can't look like. You can't throw things on the application that are unrelated to determining eligibility. We have many examples of how that happened years ago. We used to have applications, 31, 40 pages of applications. Now the federal government puts out a model application and reviews the state applications that don't adopt the model. No wrong door is a key feature of the new program, right? If you're going to have a coverage paradigm, what you need to have is a method by which people can go into the system from any door and make sure that they get evaluated for health insurance coverage and then enrolled in the appropriate program. They don't have to knock at the Medicaid door because they think they're Medicaid eligible. They can knock at any door. They can apply through healthcare.gov, the federal marketplace, if they're in a state that doesn't have a state-based marketplace. And if it turns out they're eligible for Medicaid, that same application and largely the same application review process will get them into coverage. And similarly, that applies at renewal. Database proof of eligibility, a very big change. Those wheelbarrows full of documents, you can trade them in, hopefully, and in large number of situations, you can be adjudicated eligible or ineligible based on electronic data sources. And we are now seeing states report a very high percentage of people who can be determined eligible real time. They sign up, they go into the system, they can be determined eligible in that setting. Not everybody, and not every state is quite as sophisticated as that, but that's actually what the law requires, and we're moving to broader compliance. And as I talked about, renewal is just as important, because we found we would, on best practices, we'd get a lot of people enrolled and then they'd lose coverage going on. And I think most fundamentally is that, as Medicaid director, I could say to states, you know what, if you have eligible people, they are supposed to be enrolled. It's not just a good idea, it's not just a best practice, but they are supposed to be enrolled, and there's lots of features of the law that suggest that. So very different paradigm. We've seen an extraordinary results as driven by the Affordable Care Act. And of course, there's many features of the Affordable Care Act that have promoted coverage. Medicaid expansion is one of them. But if you look at the changes in uninsurance rates from 2013 to 2015, and you break down the expansion and the non-expansion states, you see a very different, you see the same general trajectory, but you see a much deeper drop in uninsurance rates for the expansion states. But we have a long way to go. And we have a long way to go principally in those states that haven't expanded. These are the remaining uninsured. But also we have a large way to go in making sure that everybody who's eligible actually is enrolled and stays enrolled for as long as they're eligible. You probably didn't need this data when you looked at the map, but you can also see that the states that have not expanded are disproportionately Black, have disproportionately high rates of residency for Black and Hispanic individuals and people in poor health. So that's where folks reside. That's not where the expansion has been taken up for the most part. And so while we've seen in expansion states the disparities in terms of race with respect to coverage have narrowed significantly, we still see nationwide significant disparities because of the expansion, non-expansion decisions that have been made across the country. So here's my Medicaid at the Crossroads. So we've come a long way. One could say, phew, okay. Medicaid has really changed, it's really grown up, it's become a health insurer, it's delinked from welfare programs, it's got its own rules, it's got its own mission. It can move forward in peace and harmony and try and make sure that it's doing well by its beneficiaries. But there's lots of very difficult questions facing the program, and some of them are the same kinds of questions facing health insurance programs, whether they're public or private programs. Some of them are more acute for the Medicaid program, in part because it is publicly funded and the financing is always a bit of a tug of war. But some of it is also because our beneficiaries in the Medicaid program tend to be people by design, right, by the nature of the Medicaid program, who are poorer and often in poorer health. And so to make sure that we accomplish in the Medicaid program that which is generally seen as the direction that the country needs to go, or I say generally, that's a bit of an overstatement, that everybody is quite signed on to that rubric, but if we're about trying to improve health care, and to have sustainable financing for the program, sometimes it can be harder in the Medicaid program just because folks are poor, folks are, many more are homeless, are facing much harder situations economically and in their communities, as well as have poor health care. So I'm going to touch upon some of the issues that are arising with respect to Medicaid being at the crossroads. There are others, and I'm sure Sarah will jump in, and others as we move into discussion can chime in as well. So let's just start first by recognizing really the importance and the strength of Medicaid at this point in terms of driving those delivery system and payment reforms that will help improve care and improve health outcomes. In the District of Columbia, Medicaid and CHIP now represent 25% of the coverage for people in the city. 1 out of 4 people get their health care coverage through the Medicaid program. And we've been very successful in the district in terms of reducing the rate of uninsured. Nationwide, that's pretty close to what it looks like nationwide, a little less than 24%. In some states, California, for example, which has the largest Medicaid program in the country, largest in terms of expenditures, largest in terms of enrollees, 1 out of 3 Californians are now on the Medicaid program. So it's a very significant program, very significant ability to think about how to change systems so that we are delivering really terrific, high-quality care, very patient and person-centered care to our beneficiaries. But it also means that it is sometimes has a little bit of a target on its back because it is publicly financed, jointly financed by the federal government and the states. And when that financing grows, you get attention both at the congressional level, at the federal level, in terms of, oh my goodness, guess what? It's a very the costs in the Medicaid program are rising rapidly, and similarly at the state level. So just to review for folks, on the expansion, the federal government pays for the first 3 calendar years of the Affordable Care Act being in effect, 14, 15, and 16, 100% of the expansion. And then it gradually it starts shifting some costs to the states for the expansion population. The first time the states will bear any cost for the expansion will be next year, next fiscal year, 17. And it'll be 95% will be paid for by the feds. It gradually goes down. By 2020, it hits 90% federal, 10% state. So very generous match rate. The regular match rate for the non-expansion averages out, it varies by state and by the poverty in each state, but it averages out to be about 57% federal, 43% state. So even at 90-10, it's an extraordinarily good deal for states, but still there are additional state costs. And because of all the other changes that I went through, the simplification, no face-to-face interviews, no wrong door, we're also seeing many more eligible, previously eligible but unenrolled people get in the program, and they are not being financed by that enhanced federal match. So we see continued pressures and at least identification at the state level of a very large chunk of their state budget going to the Medicaid program. So lots of power, lots of market power and influence, but also a significant amount of dollars going into the Medicaid program. So I'm going to talk a little bit about some of the challenges on trying to make sure that Medicaid is using its market power and using its ability to push forward positively on delivery system and payment reform, and increasingly focusing on community health, population health. One of the big changes going on in the Medicaid program is at the state level, the majority of states have an agenda right now that is focused on these components. States in the expansion group, for sure, but also some states not in the expansion group. They're looking to improve coverage, even if they're, and to stabilize coverage, because you really have a difficulty making sure that people get the benefit of the coverage and get the care that they need if they're not continuously covered through whichever door they may be eligible. So that means not only making sure they're enrolled in Medicaid when they're eligible and stayed enrolled in Medicaid as long as they're eligible, but go back to that paradigm of coverage. It also means that if they get a raise and now they're eligible for the marketplace, that they should be continuously covered, but their source of coverage would move to the marketplace. Or if they lost a job or they have another family member that makes them now eligible for Medicaid, they used to be in the marketplace, making sure we have continuous coverage going back and forth. That's a big challenge. That's new for states to be able to be thinking about. Again, it's a requirement by law, but it really requires intensive commitment to the effort and good technology to help make it happen. States are also very actively looking at how to use their purchasing power to be more aggressive about driving for value, moving away from a fee-for-service system and trying to figure out how to pay for that elusive value. No easy task. Payment is just one part of it. You really also have to change the way our delivery systems work, and that's not just for Medicaid, but really system-wide. And then, as I mentioned before, there's an increased focus on driving efforts to come up to improve the health of communities. And this is where issues like homelessness and hunger and other economic problems that poor communities in particular face come to fore. And there's lots of studies that show that health outcomes is driven so much by those kinds of conditions. And one of the big issues for Medicaid is, do we observe that and try and go around that? Do we try and pay for that, those kinds of interventions? Medicaid is a deep pocket program, and there's lots of people that would say, people are homeless, people get sick and can't be healthy because they're homeless, Medicaid should pay for it. I think there's a balance to be struck as to what Medicaid ought to pay for and what not to pay for, but there's no doubt that there ought to be a focus on improving health in communities. Going back to the theme of the crossroads, we also have some in the country who would say that, wait a minute, I don't like this exploding Medicaid program. I don't like poor people having an entitlement to health care. I think we need to have the kinds of things that are in place in welfare programs to push people in and out of the program as quickly as possible. And so we have seen proposals come up from some governors, and now we've seen a couple of them emerge at the federal level in the Energy and Commerce Committee on the House side, where they would say, we want to have work requirements. We want to make sure that if you have somebody who has zero income or no employment, who's getting Medicaid, shouldn't they be working? There's no asset test for the Medicaid program for the under 65 group that are eligible under that new coverage paradigm. There's no asset test for the marketplace. There's no asset test for CHIP. But it's only Medicaid where we've seen proposals that says, let's have an asset test for the Medicaid program. If people win the lottery, they shouldn't have health care. And we've also seen a proposal emerge about time limits, which is, again, a carryover from the welfare paradigm. People shouldn't be on Medicaid forever. They should move on and improve their economic standing and be able to, and be forced to leave the Medicaid program after a period of time, or else this will interfere with work incentives and a drive to improve themselves economically. These are programs, I would argue, are inconsistent with Medicaid's role as an insurer. It's really not about the purpose of the Medicaid program. It's not that work isn't a good thing for people. It's not that people shouldn't have job training and other opportunities to improve their economic status. It's that, is that really the purpose of the Medicaid program? So that's been a tug of war between the Department of Health and Human Services and some of the states that have come in with requests to have waivers, special dispensation from the HHS to say, I'll be willing to expand, but I only want to expand if I have these kinds of components. And now we see some of these proposals emerging at the federal level. So this administration has determined that these are not policies that will be approved through waivers. Waivers are conditioned on a policy being found by the Secretary as furthering the objectives of the program. And she's determined that these won't further the objectives of the program, but they will continue to appear, both as states continue to bring it to a new secretary after this administration ends, and as we've seen pop up in the Congress as well, and to have a change in federal law. We've also seen a lot of states be more interested in adding costs, out-of-pocket costs to consumers on the theory that it's good for people to have skin in the game. It makes them understand the value of health care, appreciate it, lower utilization so that it's only necessary care, all the things one hears about. I pay copays, I pay premiums on my health insurance coverage. Why shouldn't poor people do that as well? My general answer is because they're poor. And it's not inherently a bad thing, but it is a bad thing if we make Medicaid unaffordable, which is, of course, a key goal of having that continuum of coverage and subsidy, is it slides with income and the idea that people at the lowest end of the income stream need significant subsidization and full subsidization when they have no income. So this is an area where the administration has been willing to give some waivers around premiums, but have drawn some lines. So on premiums, you can do premiums. They can't be more than 2% of income, and below poverty, it cannot result in the loss of coverage, has been the condition so far on the waivers that have been granted for in this area. Co-payments, the law actually allows states to do co-payments, and it is pretty circumscribed what the waiver authority is. So only one state has gotten a waiver on co-payments Indiana with respect to non-emergency use of emergency room services. We will also see, and you're beginning to see this play out now, and I suspect even more so in January, is a fight that has been, going on off and on for the last 20 years or so, which is whether the very nature of the Medicaid program should change in terms of its financing. And basically the way the Medicaid program now works is it's jointly financed, as I mentioned, and if costs go up, if more individuals apply for the program, if there's a new drug, Sovaldi comes on for Hep C, that raises costs, that the federal contribution automatically conforms to what the costs are. So if it's 57% of the costs or 90% of the costs are paid for by the federal government, what those costs are, assuming that they're well managed, it's medically necessary. There's obviously rules as to what can constitute a legitimate cost, but there's no cap. There's no amount by which the federal government says, well, I'm only giving you that much and no more. We have a lot of programs in the federal list of programs that are capped. Housing assistance, for example, is capped, and so you see people on waiting lists to get housing subsidies. But there's no waiting list for the Medicaid program, in at least the basic parts of the Medicaid program. And the idea is that it's an entitlement to coverage, and because it's an entitlement to coverage, an entitlement to the benefits provided, then the federal and the state governments need to pay the price for that and think about how to manage the program as smartly as they can. We've seen over the years a fight about block granting the program, which says we're going to put all of it under a cap. And we've seen variations on that that says we'll put each person in a cap, or each category of people in a cap, so that it would accommodate growth in enrollment, but not growth in the cost of benefits and care. So that's some of the key issues facing the program now. I think they're all hard issues. It's not just, will the Congress fundamentally change what's going on in the program in terms of financing, but it's just as importantly, how will we tackle providing better care and doing positive payment reform at the state and the community level?